I was discussing the topic with Dr. Shashi, and she thought that this would be a good topic about how the optimal use of HPV testing in gynae practice, because now I think the time has come that most people are familiar with this test and they are doing it. But still there are many people who will say, I am doing pap smear regularly, why do I need to shift to HPV testing? Or what is this benefit over pap? What are the disadvantages? And are all HPV tests the same? Of course, we know for a long, long time that pap smear screening done regularly is beneficial. There is no doubt about it. It has proved itself. At the same time, it requires to be done very repeatedly so that sometime in that natural history you will catch the patient, because inherently the sensitivity is poor. A single test will detect only 55 to 60%. This is the result of systematic analysis and reviews and meta-analysis from North America and Europe, and not just from LMIC. So if you can do that, yes, we could find that there was a decrease in the incidence of invasive cancer. A decrease in the incidence of invasive cancer, a decrease in the mortalities, and a rise in the precancerous detections. So what happened that the WHO, when it announced the elimination of cervical cancer, said that 70% of women should be screened with an effective test, by which at this time they mean the HPV test. None of the others is qualifying. So what is the reason for saying this? And if we look at the journey of HPV testing in our cervical cancer screening paradigm, it actually first came in as reflex testing for ascus. In countries where it was already well established, they thought they have seen the best of the benefits already anyway. They just used it as a triage tool. Then gradually, as more data came, it became co-testing. Let's do both. They couldn't shake off the pap. They were so used to it. And then came a situation now where we do primary HPV testing. So I will show you this slide, which looks a little complicated, but it isn't really. And this was the work that came out long back, 2007. You can see the ALTS trial and all, which showed that what is the risk of precancer. You can see here the increasing risk of precancer. And you can see that if the patient is cytology negative, she is, of course, in the blue zone. But if she is HPV and cytology negative, then she is even lower down in the blue zone. And an HPV negative ascus is only marginally worse than a cytology. Whereas an HPV positive cytology normal is actually a more sort of a risky situation. And then you have ascus, LCIL, and HCIL up here. So you can see an HPV positive ascus becomes almost as bad as an LCIL. So that is where the co-testing philosophy came in, that by doing both, so you had an ascus, you did an HPV, it became an LCIL. You had an ascus, you did an HPV, it was normal, it went down there. So that's where the co-testing came. And as Albert Singer once said to me, that the reason that they liked the LBC was that in UK, the women would get stressed if you gave the diagnosis of cytology positive, so they would automatically use that to do the triage testing, reflex testing on the same sample, so that they don't have to be given the diagnosis one at a time. And of course, you can see that the HCIL, who is HPV positive, is the worst situation here. Thank you. I'll take it. And then these are the situations post-colposcopy, the follow-up. So in the follow-up, if the HPV is negative, that's the best test of cure. And if the HPV is positive and the cytology is negative, that's a bit better than the ones who are just HPV positive of unknown cytology status. So this is in a nutshell how HPV positivity changes the whole game of outcomes. And it was concluded at the time that women with concurrent negative test results of PAP HPV, both normal, can be reassured that their risk of unidentified CIN2, CIN3 or cervical cancer is approximately 1 in 1,000. So nothing is 0 and nothing is 100 in medicine, so it's somewhere. And in fact, the International Agency for Research on Cancer, way back in 2005, said that there is already sufficient evidence that the efficacy of HPV testing using a validated system as the primary screening modality can be expected to be at least as good as that of conventional cytology 20 years ago. So if we just take a look at the human papilloma virus types, which we know, more than 200, low-risk types like 611 for warts, high-risk types, currently 17 are being defined as high-risk, 16, 18 are the worst, 16 is the most, as you can see in this chart. So you can see in the bar that 16 is the worst, then 18. These are the ones in our basic first-generation vaccines. These are some types which might get covered by cross-protection because they are related. So at the end of the day, the extra types for which the 9-valent really offers protection is not very much more. And I say this repeatedly, that if we are looking at cervical cancer protection, even the quadrivalent is actually good enough. But if we are looking at protection against an abnormal CIN, abnormal PAP report, an abnormal HPV report itself, which is not less. I don't know, people think about the cost of the vaccine, but if you think about the cost of repeated testing, triage, treatment, and all the other things about the psychological impact and the social and all of that, it's actually nothing at all, and that is where the nonavalent really scores. And there is no doubt that anybody who can afford it should go for the nonavalent vaccine. But from the cancer protection point of view, definitely we are fine, because while the global average of HPV 16-18 used to be 70, latest data says 77. Actually, as other places the cancer is declining, main burden is India. And main burden India drives it because our 16-18 is much more. Ours is 84%. So that is the reason. So again, this chart looks very complicated. So this is the IARC's latest position on the relevant importance of the carcinogenic types. So in the first column, you see all the carcinogenic types, even the ones that were previously considered carcinogenic, no longer considered carcinogenic. Then the species they belong to and the groups. Now here you see their percent prevalence in cancer, the percent prevalence in normal, the odds ratio, and the percent attributable fraction, which we say that so many percent of this cancer are caused by this type. And you can see that in the normal, you don't often get the 16 report, and everybody says कि 16 तो बहुत कम आता है. तो normal में कम आता है. They are like race horses aligned at the beginning, and then the aggressive ones get ahead. So as you go to CIN, they become more common, these types 16, 18. 18 is only 1% in the normal, but it becomes 14% in cancer. So the percentages of all these various types you will get in the HPV report, but the risk that they will progress to cancer is definitely different. So important is, this is the WHO guideline for screening and treatment, which is a free download, and you can use the QR code also to get there. A report of HPV test positive does not mean the person already has CIN or cancer. There's absolutely no reason for them to jump to a hysterectomy or anything. In fact, that's the worst strategy. The next step is to triage, to determine which is the subset which is at risk of CIN or cancer. And various triage options have been laid down in these guidelines. So why is 16 and 18 so important? When you follow up women, and I will concentrate on the ones more than 30, though it's similar, but this is the age group in which we now do screening. These were all research studies. So if they are at baseline 16 positive, see the cumulative incidence rate as they have gone 10 years down the line. And this is 18. But other HPV types going to cancer is relatively few. Of course, we don't know which of them will. We still have to look for those tools, so we have to treat them all. So the second generation of HPV, the first generation of HPV test that came was just a cocktail of 13 important types. So it did not tell if there's one or there are multiple infections, how much infection exactly. But the second generation has incorporated, like COBAS, the partial genotyping so that 16 and 18 are told to you separately. And these patients are more likely to persist, they are more likely to progress. And so these are the ones where you should err on the side of treatment. Take a biopsy and do a thermal ablation if she fits the criteria, or a leap, whatever is required, because these are the women, will they come back, won't they? They're not, loss to follow-up is not restricted to social classes. And the see and treat programs actually developed in the colposcopy clinics in the West, where the women over there also would be lost to follow-up. So they said if the cytology is positive, now cytology sensitivity is poor, but specificity very high. If you have a normal cytology, she may or may not have disease. It cannot be sure. But if she has an abnormal cytology, it's almost sure that she does have disease. You have to see where it is by the colposcopy, right? So suppose she came with an abnormal cytology to the clinic, and on colposcopy you saw a high-grade lesion. And now if you do a treatment, even a leap on such a patient, the risk of over-treatment is very low. The chances are that you would have done appropriate. The worst chance is that there may be a cancer missed and then you have to go back to treat that. But that you can always do the post hoc. So these are the patients that we should look for it. And thermal ablation is a great thing and everybody should have it in their armamentarium. So what is this validated testing that we are talking about? Well, we must understand the concept of clinical sensitivity versus analytical sensitivity. Now, sometimes the PCR can amplify and detect copy numbers which could never give you any clinical significance. And you will be just unnecessarily, they will be tormented, they will have to follow up, they will have to do all that. And on the other hand, if the primers are not sensitive enough, you will miss it because the smaller primers only detect the smaller fragments. So we have seen this actually in our own laboratory. So if you're doing one of those unvalidated, somebody's homegrown in their own lab type of test, you cannot use it alone for primary test screening, that's for sure. So I say that it's not about transition to HPV testing, but it's also about transition now to validated HPV testing. And these criteria are quite stringent. Excuse me. They define how the sample has to be picked up, how many patients with CIN2, how many with CIN1, or they are going to use a comparator test which might be clinically validated already, and look at the benchmarks. The relative sensitivity, 0.9 for CIN2, 0.95 for CIN3. Relative specificity, 0.98. So very, very stringent criteria. And also demonstration of inter-lab reproducibility. So all these tests that we have gone through this and are validated. Hybrid capture, as I said, the one we used earlier, really done, all the big studies have been done with this, and it's a very good one, but it tells all the types combined. So now we have this limited genotyping in HPV16 in COBAS. This is the one used maximally throughout the world in most programs, whether it's Australia, UK, US, and everywhere. And now we're coming into another generation of extended genotyping, which will further break down the result and tell you which ones are there. And you have OnClarity, which is now beginning to come. Cepheid is there, Gene Expert, and there are others which are not widely available here. So this full typing which the labs give you, even these, if they have to be done, should be by validated tests like you had earlier, the Roche test, but now that's not coming. Then you had some Inolipa. Now you have Cgene, which is another Korean company which is producing Allplex, Aniplex. So even for the full typing, these are the ones, but they are mostly used in research. So in India, we actually conducted a validation study of a fewer genotype test, 8 genotype test. Because the theory behind this is that we said at least 7 of the nonavalent, but then by the time we started, the WHO had come out with this thing that you should have at least 8. So in that chart which I showed you, the 7 first are the nonavalent ones, and there's 35, which is actually a big omission in the nonavalent vaccine, because that's the type which is very common in Africa, and it's also in our meta-analysis, we saw that in South India, it is more common, 35, than in North India. So then we added that 8, and TrueNat was able to pivot and give us, so we had 4 tests which we studied, And we used all this. We got the samples, biobank samples from IARC, and did this quite meticulously in 4 labs. There was 3 labs in Bombay, in NIRRCH, in NICPR in Noida, and at AIMS. And we did the cross exchange of samples also. And we got this all-plex done at Belgium to clarify. So I'm almost getting there. So in this one, their turnaround time is just 60 minutes and 90 minutes respectively. And in this, we found that TrueNat complied with all. So why 8 types? So yes, we will miss some of that poonch, which were going to contribute very little in terms of cancer risk, but they were going to cause a lot more patients to be referred for triage. So as a public health one, we hope that this will be the sort of one which will make it, because this test is already being done for TB. And so this guideline I showed you, the algorithms are there for whichever you choose, whether you choose VIA, HPV, cytology, they are all backed by data. But yes, HPV is the best, and the screening and triage is also defined, how you can use 1618. You can determine eligibility instantly, as I mentioned, for the ablation eligible. If not eligible, you can do the LETs, and then you can follow up and see what is their status. And this is the kind of PPV for the detection of CIN3+. If you go genotype-wise, it varies. So this is one thing which I will just touch on briefly, that now ASCCP has moved beyond this and said you have to base the risk recommendations on risk, not on results. So if, depending upon how they stratify the risk, and they have algorithms for that, they decide whether you are coming back in 5 years, 3 years, 1 year, colposcopy is to be done, or the expedited see and treat acceptable or preferred. So this is the way you can actually really make it very granular to decide. But they prefer the excisional if there is CIN2-3, and excision only for AIS. So it's in this era of personalized healthcare, they have also gone beyond to say that there can be extended genotyping for individualized management. 1618 undoubtedly immediately refer, immediately manage, but the other ones you can do a triage with cytology or dual stain, and then you can follow up according to the reports. Whereas if they are 56, 59, 66, they are lower risk, you don't have to worry, and you can repeat in 1 year. So I've already mentioned about HPV as a test of cure. So just to put some take-home messages, there are genotypes with varying oncogenicity. 16, 18 are the most virulent. These tests are available in a variety of configurations, but using a validated test is of utmost importance, and you can integrate this genotyping result into your triage. And because, as I said, it's the vaccine day, I just wanted to end with pictures of Madam Nirmala ji's announcement 2 years ago, and thank God we are there, Modi ji in the Quad meeting later in that year, and now today finally 11:30 a.m. today, a national program, live telecast 11:30 to 11:45, followed by each state having the launch in their own states as well, starting with the 14-year-old, so happy days. Thank you. And thank you for giving me the extra time also.
Thank you, ma'am. As always, it is our privilege to listen to you. Ma'am, I just wanted to ask you, what should we do? Should we prescribe nonavalent or quadrivalent to
so I think
patients?
Anybody who can afford it should take the nonavalent, because as I said, the risk of getting an abnormal HPV report itself is diminished. The risk of CIN, which we are seeing regularly nowadays coming from IVF clinics, that they go there for IVF, Dr. Jaideep ke paas bhi aati hongi, and then they are found to have CIN, and then the whole plan is off track. They wanted a baby this year, they want the baby, so they want the baby. But now their whole plan is gone, now it's CIN, and by the next year, the marriages have even broken up. The whole story has changed, so It's very, very bad. I think nonavalent, single shot up to the age of 20 years is
So
perfect.
it is now
It's single shot for
single
Gardasil
shot,
4
yes.
and 9, but yet Servavac data will come next year. So
we can-
Servavac, maybe you can advise a delayed dose and say, आज लगवाइए फिर 3 साल में लगाइए, that's all
So
right.
we don't have to ask for second dose below 20 years.
No. And
either-
21 के बाद 2 dose and
Okay.
HIV 3 dose.
Okay, ma'am.
Or
Okay.
even transplant
Yes.
patients. Or
Yes, yes. Thank you so much, ma'am. It was great help.
It's absolutely fine to do it. It's absolutely fine to do it. You know, there are some data from the West that say that one-third of people have already acquired the infection by the age of 30 years. But somebody was alerting me to the fact, I wanted to bring those graphs and I didn't get them yet, that in the NACO and all, they've done some studies on sexual practices, and actually our patterns in India are very different. That we are usually monogamous in the early phase, and then we become straying in the middle phase. By we, I mean, you know. So, but bhugatna to lady ko hai. So it may be a good idea actually to encourage them to take it and protect themselves. Why not? You can't change what you can't change, and you don't know what you don't know, but why start to wonder? So let them take it. There is no harm done at all. It's a safe vaccine, but because the advantages are less at that age, nowhere in the world the government will pay for it.
Ma'am, till what age we can give?
Up to 45.
45.
Once the transformation zone has become quiescent after menopause, there's not much risk after that.
So up to the age of 45, 2 doses only.
2 doses. Yeah, 2 doses. 2 doses till 45.